Hello, welcome. Thank you for joining us. My name is Dr. Brandon Bosque. I'm a board-certified podiatrist and certified wound specialist physician. And today I'm excited to be here with my friend and colleague, Dr. Brian LePow. He's assistant professor of surgery at Baylor College of Medicine in Houston, Texas. Thank you so much for joining us today, Dr. LePow.
Thank you, Brandon. Looking forward to being here today.
Absolutely. So today, Brian, what we're going to talk about is a publication that we worked on together in collaboration with some wonderful authors, literally an international panel from the United States, obviously, Canada, as well as New Zealand, looking at real-world data, what 2,200 DFUs tell us. So to start off, before we get into the publication, Brian, I wanted to talk about these unfortunate facts that you and I know intimately well, and a lot of our audience tuning in knows as well, that this problem of diabetic foot ulcers is a growing and global problem, with over 166 million people worldwide at risk of developing a DFU. And of those folks, 1 in 6 at risk of suffering a life-altering lower limb amputation. Of course, that's very impactful for our patients' quality of life, but when you look at it even from the financial lens, we know how expensive and costly this could be, with estimates between $9 and $13 billion in cost burden in the United States healthcare system alone. So my question to you, Brian, is, does that translate to what you're seeing in your patient and your community down in Houston?
Brandon, yeah, it is very much so. I mean, all these global statistics, are pretty similar across the board. And in Houston, where I practice, there's still continues to be a very high rate of amputations in the city itself, and we're fortunate to be there to help sort of curb that. But yes, the burden of the healthcare system continues to grow. As we manage these patients, try to find ways to manage them better. So yes, all these statistics that you mentioned are pretty representative of my day-to-day practice.
Well, Brian, I'm glad you mentioned that. So one way that we can combat this is by practicing good evidence-based medicine, right? And
Correct.
The way we can develop that evidence and look at that evidence is to contribute to the literature, which we were able to do in this publication, but also when we're looking at the literature. So we know, especially in medicine in general, randomized controlled trials are the gold standard, as it should be, right? But we know in wound care, the emergence of real-world data has really kind of taken things by storm, especially pioneered by the great Dr. Caroline Fife, a fellow Houstonian as well.
That's great.
So when you're sitting down to look at the data and you're looking at medical literature, where does randomized controlled trials and real-world data fit in terms of your wound care practice?
I think you touched upon it. I think the randomized controlled trials are sort of the gold standard when looking at these particular populations. The one issue that I sort of have with those is that those sample sizes and that population is really not sort of what we're seeing in our clinics. It's very rare that you see a healthy diabetic foot. And I think in a lot of these RCTs, there's so much inclusion-exclusion criteria, it sort of limits the patient population that we're seeing, and it's not representative of the true patient population. And I think that real-world data really it speaks sort of more volumes to the population that we see in our clinics. You get a much larger sample size, which I think is important, and plus you're limiting sort of that inclusion-exclusion criteria, and these patients again are typically very sickly, and a lot of the exclusion criteria sort of overlooks the unwellness of this patient population. And so if you remove all that, then you're really not looking at a representative population.
Right, Brian. These are complex patients that have poor circulation. They're older, they have cancer, they have high uncontrolled diabetes. So when we exclude them from a randomized controlled trial, it makes sense. We want to minimize those variables, but that's not reflective of the patients that we're seeing, especially you're seeing down in Houston. So I think real-world data, as you mentioned, is a great adjunct to that. Randomized controlled trials have a phenomenal place in medicine, will continue to be there, but in wound care specifically, the large sample sizes, the less restrictive inclusion and exclusion criteria really does reflect the complex patients that we're trying to heal. So
that's true.
So what we're able to do with that in mind was develop this fantastic manuscript, again with authors from all over the world really. And what this manuscript here entitled Retrospective Real-World Comparative Effectiveness of Ovine Forestomach Matrix and Collagen ORC in the treatment of diabetic foot ulcers, it was really the first large real-world data study to compare healing outcomes of two comparable products head-to-head. So we really appreciated your input into this study as well. So let's kind of break this down, this study, and really dive into what it means and and the type of outcomes that we're able to generate from that and implementing that into clinical practice. So we'll start by looking at the two products head to head. So this graph here is really great to highlight how these products are similar or dissimilar in this instance. So on that top row there, we have human tissue ECM. So of course, we know that the extracellular matrix of our soft tissue is very dynamic. It has a ton of different proteins, all with different jobs: adhesion molecules, structure molecules, chemotaxis, cell interaction. So this is definitely not a holistic, it's a representative look at human ECM. So of course, not just type 1 collagen, but multiple collagens, fibronectin, elastin, glycosaminoglycans, growth factors. All those components are found in our normal ECM. And we could see in that second row there that Endoform, or ovine forest-stomach matrix, biomimics a lot of those same proteins, whereas collagen ORC, kind of the traditional collagen dressing, is simply just reconstituted collagen, exactly what the name implies. So my question to you, Brian, is when you're looking at this, and if you were looking at the study, seeing these products be so different biologically, is it a fair fight? Why would we study these two products?
Yeah, I mean, I think that's a great question. I mean, look, definitely someone could look at this and say, well, you're not comparing two like products. And we're not, but in terms of the ease of access, the ease of use, this is kind of where, we kind of want to, drive the message home about the likeness of these two products. In a couple of instances, I think in a lot of cases, sadly, a lot of the physicians aren't quite aware what the differences are in terms of the biological makeup of these products. Not to say that they shouldn't be or they shouldn't do their homework about the products they're applying, but they may not know. So they realize, well, this is what's available in our clinics. We have them off the shelf. They can be used from day one. And so they go to those products that have least resistance, that don't require prior authorizations. They don't require 4 weeks of a non-healing wound before they apply these products. And so I think this is where these two products really kind of work hand in hand together.
Brian, you nailed it. So again, the real key and why we compared these products was access, right? You can, like you said, you can apply it on day one. It's in the hands of anyone, whether it's the provider, the nurse, a trained family member. So again, that's really the key. So while they are quite different biologically, the reason why we wanted to study these healing outcomes side by side is because they have very similar access points, being collagen-based dressings in the outpatient setting. So great point there. So let's talk a little bit more about the study itself. Let's get into the nitty-gritty here. So what we were able to do is look at data across 449 wound care centers across the US. And we started with a pool of over 25,000 patients. And with this very loose inclusion and exclusion criteria, we wanted to just look at just DFUs, DFUs that had at least 2 treatments, right? Because you don't want just a one and done, of course. And we wanted to exclude patients that were under palliative care or had both products applied. So we found 1,150 patients that just had Endoform applied across, 1,150 DFUs across 807 patients, and 1,072 DFUs across 783 patients with the collagen ORC exclusively. So my question to you, and you talked about this before, was what does this sample size mean to you, especially when you're comparing it to a randomized controlled trial?
Yeah, I mean, I think the greater the sample size, the better, evaluation that you can have for these products. With these small sample sizes, 50, 100 patients, while that's a decent, size, I mean, you're talking about 1,000 plus patients. The more patients you have, the better you can sort of analyze and look at the data. It provides, again, that sort of realistic, real-world evaluation of this population and what we're really seeing. So I think I always, in agreement, the larger the population you can get, the better outcomes you're going to wind up having, and you can kind of determine sort of, what is and what isn't working for this particular population.
Less chances of outliers and things like that. Correct. You're exactly right. I love it. So let's talk about the baseline demographics and characteristics of the patients themselves. So on the top, you can see the Endoform cohort, and then the bottom, the collagen ORC cohort. And if you look at the variables, the gender of the patients, the age of the patients, the A1C of the patients, pretty comparable between the two, at least statistically. Of these variables, Brian, any of them really jump out at you, meaning that we really wanted to make sure that they were as close and comparable between the cohorts as possible?
Yeah, I mean, if you're going to do a comparative study, again, with non-like products, I think having as close match populations as possible is great. And I think looking at the A1C is probably one of the things that a lot of studies overlook is looking at those A1C levels, because we have patients that have A1Cs that hover in the 10 to 12s, and that may be their average and normal. So having things standardized, specifically looking at the A1C levels and having that standardized, I think only creates a healthier look at these particular two populations.
You're exactly right. If one cohort had a baseline A1C of 6 and the other one had a baseline A1C of 12, then that's not really a fair fight. But seeing that they're right around the 7.2, 7.3 range, very comparable A1C, so we expect that those baselines would not affect the outcomes of the study.
You can just controlling for factors a little bit better.
Exactly, and that's really the beauty of it right there. So taking another deep dive here, now we're looking at the baseline characteristics of the wounds themselves. So we have the wound area, about 2 square centimeters in the Endoform group and 1.5 square centimeters in the collagen ORC group. Pretty representative of, being the podiatrist, what we see. And again, about 1.5 wounds per patient. Obviously, we saw that there was a greater number of DFUs to patients, so we expect that as well. And then the general age, so about 15.8 weeks of chronicity or wound age in the Endoform group, and 14.5 weeks wound age for the collagen ORC group. So again, same question. In these variables, anything really jump out to you between the two cohorts?
Again, pretty comparable when you look at the two populations. I think the two things to note is in the Endoform population, you had a bit larger square, statistical significance, in fact, in terms of the size of the wound, and then the age of the wound is a bit longer. So a little more chronic wound in that particular population. Not extensive to skew the data, but there is a difference there. And as you note, there is a statistical significance between that in the wound area. So I think that's really important to highlight with the two comparative products.
I would agree with you. That was very interesting when we were ready to look at the results. We say, okay, well, we in theory start with a larger wound with the Endoform cohort and a little bit of an older wound, more chronic wound. So it'd be interesting to see what the results showed. And so let's without further ado, let's look at the results. So so this first bar all the way to the left is the entire cohort. So all 1,000 some odd wounds in the Endoform group, all 1,000 some odd wounds in the collagen ORC group. And what we saw was about an 11.3% reduction in the time to close. So basically what it's saying that the Endoform group is closing almost 2 weeks sooner, about 11% sooner. And then the other 3 bars to the right there are actually different subgroups, so requiring 4 or more visits to the wound center, 8 or more visits to the wound center, or 12 or more visits to the wound center. So we know if they require more visits, that's more of a complex wound, right? And as we saw, the delta is widening the more complex the wounds, right? Maxing out in that third subgroup, showing up to 5.6 weeks sooner healing time with Endoform versus collagen ORC. So Dr. LePow, tell me what that 5.5 weeks or even that 2 weeks means to your patients and to your practice.
Yeah, I mean, I speak about this a lot, and I think it makes a huge difference. I think a lot of us and a lot of people just in general in the community don't realize that 2 weeks, even 2 weeks, is a big difference. You're talking about quality of life for the patient. That includes multiple doctor visits. If you shave off that time of the 2 weeks that they would need to have home health coming out to service their wounds and manage them. There's a cost perspective as well. These patients are coming to the clinics. They are sometimes needing hospitalization. The longer that these wounds are open, the higher risk they are for developing infections, complications. That includes hospitalization, sometimes surgical debridement management. And those hospital lengths of stay tend to climb up there. A lot of these patients are very complex, have complex vascular issues, and every time that patient comes back to the hospital, not only do they generally need a procedure by myself to clean the wound, but typically they're going to need an angiogram or some other type of procedure to ensure blood flow is maximized. So that 2 to 5 week difference, I think, is huge in terms of sort of the global scale of management of these patients.
You're exactly right. And again, the goal is limb preservation. So the longer that wound is open, the more of a chance that something goes wrong, that unfortunately they could require a major amputation. And that's really the goal, what we're trying to avoid here. So really compelling numbers to see that the more complex the wound is, the better chance that Endoform will heal them sooner. And like you said, 2 weeks or 5.5 weeks, man, that is enormous for our patients and for our practices.
And it's a major quality of life issue. I mean, these are patients that have families, need to get back to work, and so if we can get them there 2 weeks sooner, that's great. Again, all the supplies that are necessary. A lot of these patients have negative pressure. All these things that we don't necessarily think about that I think are really important to highlight with these types of findings is that the longer that they're undergoing care, the greater the chance that they're going to have a complication, and that could lead to ultimately an amputation. Because they may not necessarily wind up back in our hospital. If this patient becomes sick, they'll wind up in a community hospital, and they might not be so lucky to get into a limb preservation program where somebody actually knows what to do to these patients, and they wind up getting amputations. You and I both see it all the time. It's really unfortunate.
Yeah, you're exactly right. You're exactly right. So now let's kind of dive into the weeds a little bit more with kind of a statistical analysis here. So what we were able to do here was a Cox proportional ratio to kind of show the increase in probability of one product being used to heal a wound versus the other. So depending on what you read, sometimes they want the data to be adjusted or left unadjusted, raw data. So what we did was we looked at both. Okay, if we adjust for certain variables, does that change the data? Or if we leave it raw, does that change the data? So what we found, again, similar to the graph before, for the entire cohort, the way you read this is for the adjusted data, treating with Endoform gives you a 21% increase in probability in healing compared to collagen ORC. And when you leave it unadjusted or raw, it still gives you an 18% increase in the probability of healing using Endoform versus collagen ORC. And much like what we saw before in the results, the more complex the wound, the more treatment visits that they require, that delta widens. So you have more of an increase in probability of healing utilizing Endoform versus collagen ORC, with the most complex wounds showing up to a 38% increase and the probability of healing with Endoform to collagen ORC. So again, when you're looking at statistics, Brian, what does 38% increase in probability of healing mean to you when you're developing treatment protocols?
Yeah, Brandon, look, it's really kind of what we already touched upon. You're talking about reduction in quality of life, the longer that they're managing these wounds, healthcare costs, and ultimately return to work and life. So if you can have that probability that there's a 38% chance that they're going to heal faster, why wouldn't you want to
take those chances anytime?
Exactly. Right? Our job is to get these patients moving quicker, back to diabetic foot remission, as we call it, and really back to living their lives, back to their families, exactly, providing and taking care of
any advantage that we can take for our patients. Why not go for it, right? Exactly. So to kind of summarize here, again, this was a large real-world data study that compared two similar products, similarly accessed products, head-to-head with over 2,222 wounds in the entire cohort. Really, really big sample size to your point before. And what the data just showed that we went over is that you have up to 5.5 weeks faster closure utilizing Endoform versus the traditional collagen dressing, collagen ORC. And for the statistical folks out there, a 38% increase in the probability of healing when you're using Endoform to collagen ORC. So for me, we're always reading data, right? And our colleagues are always reading data. But something like this, how do you translate this type of data into actionable clinical protocol and treatment options?
Yeah, I think it's a matter of education, right? Educating those that are doing the work, what's available to them. I think a lot of the clinicians that are in these wound care centers and these wound care programs sort of just use what they have access to and or what they were trained to use. A lot of us, the reason why we use certain products is because that's what we used back in training.
Back in residency.
Back in residency. My early entry to Endoform was when I was a fellow, and this was before Endoform was even in the marketplace. Not that I continue using it because of that, but I know that the outcomes are good.
Right.
And I think that's certainly part of it. Is that it's sort of how do we continue to educate our colleagues about upcoming things that are newer, and then studies such as this, where it's not necessarily an RCT, but is a real-world comparative study looking at two products that are widely used throughout our centers, and sort of educating them on why would you choose to use one over the other, and let them see the data and make the decision for themselves. But I think given here the large sample size, the 5 week, almost 6 week ability to close those wounds faster, and then that 38% reduction in healing. Those numbers speak significant volumes, and anybody who's looking at this should take a step back and look at their population to determine, well, how can we do a little bit of a better job for them?
Exactly. That's what it all comes down to, is to take any advantage possible to get our patients better sooner, and this type of study really drives that point home. So, Brian, I thank you so much for helping us put this publication together, and also for joining us today, and for all of you watching as well. So I think the real key is, when you're looking at studies, especially in the wound care literature, is looking at randomized controlled trials, respecting them, but then also utilizing real-world data to be an adjunct to that, so that you can really say, okay, in a real population, these are the findings. How can I change or adjust or even have my practice treatment protocols validated? So again, we thank you very much for joining us. And Dr. LePow, again, thank you so much. It's always a pleasure seeing
Thanks,
you, my
Brandon.
friend.
Appreciate
Okay,
it. Yeah.
thank you so much.
Good to see you.
And we appreciate you. Take care.